So, welcome everyone. We are doing METs and simulants today. So we got a couple of people. You still have not gone into labor.
Not yet. Okay. Everyone told me you do eventually, so. Today's my last work day, though. So if I'm not here tomorrow, it doesn't mean I had a baby.
Okay. But you said your mom was late too, right?
Mm-hmm.
It's usually predicted.
This is being recorded until I got to Sorry, I'm sharing that information, Mom.
Sorry.
Hi, Mom.
Love you, Mom. Okay. So one's in focus. Okay. So first off, Shane, what do you think? Clue to anatomic site.
They look like smooth muscle.
Yeah, so lots of bundles of smooth muscle, kind of haphazardly arrayed. What kind of skin would normally have smooth muscle?
Like genital skin?
Like anogenital, which is usually smaller wisps. And then when you have bigger bundles like this, it's usually nipple. Okay. So, you know, that's a clue to breast, the larger muscle bundles like that are all smooth muscle. So we've got something.
Something that's glandular. There's like a stratifying squamous or even maybe like a columnar.
Yeah,
it's
like
loose.
Columnar with decapitation secretion,
Mm-hmm.
which would be what kind of differentiation? Apocrine. And then surrounding it, you've got this layer of round cells that you could stain with something like P63 and they'd be positive.
So they can like add like an add.
So that's a myoepithelial layer. So it looks like there's a myoepithelial layer at the base. Tells you it's not a MET, right? Because a MET wouldn't take its myoepithelial layer with it, right? So it could be DCIS or it could be something completely benign in the duct, but it's not a MET. Okay. What kind of things are kind of bland and apocrine in a nipple? Looks almost like a HPAP, but sits within the nipple duct. So anyone want to?
Nipple adenoma.
Yeah. So benign intraductal papilloma, nipple adenoma, erosive adenomatosis of the nipple, they're all the same thing. So erosive adenomatosis is a clinical term. Benign intraductal papilloma, nipple adenoma, they're all synonyms. And it basically looks like an HPAP that is sitting within a nipple duct, mammary duct. If you have the same histology in the vulva, it's an HPAP. If you have the same histology in an ear, it's an HPAP. They give it a different name in the nipple. If you have something that looks similar but is a little more solid on a digit, you worry about what? Aggressive digital papillary adenocarcinoma, and if it's in a lid, it's probably a fellow question. Endocrine mucin producing carcinoma. So the life of endocrine mucin producing carcinoma starts in a hydrocystoma on the lid. The hydrocystoma starts to get a little complex, a little buddy, and then it starts to look like a cystadenoma or HPAP. And then it ends its life as full-blown mucinous carcinoma and tends to pick up neuroendocrine markers. So an HPAP-like histology in nipple is benign nipple adenoma. On digit, be cautious about aggressive digital papillary adenocarcinoma because benign papillary things don't tend to occur on the digit, and same in the eyelid, where it can be a marker for endocrine mucin-producing carcinoma of the lid. Okay. So, tough case. Well done. Okay. Let's let everybody get into focus first. Oh, good. Okay, good. Looking to see if people are still getting focused. We've got momentary pause here.
So you have these glandular structures in the dermis. From here, I worry a little bit about an adenocarcinoma.
So certainly looks hypercellular. They're not particularly round or oval. They're bizarre irregular shapes. When you look at the center, there are a few inflammatory cells, but there's also a lot of dirty necrosis in the center. Some goblet-y type cells. So what are you thinking?
Worry about like metastatic colon.
Yeah, so that's kind of typical for colon, and this actually was not a MET. This was someone with an ostomy, and was treated for 5 years for dermatitis of the ostomy site, and it was adenocarcinoma growing into the surrounding tissue, all kind of friable red growing out from the ostomy. So a primary adenocarcinoma in the ostomy site rather than metastatic, which is actually better. It's better not to have a MET, right?
So, broken pieces of neoplastic-looking tissue.
Yeah, so pattern may be tough, but if you had to characterize the cells, the cytology, where would you put this?
I mean, I guess there's some areas where they seem to be like box carving and nuclear molding. I'd worry about just breast because it's common on the skin.
Sure. A little bit of nuclear molding like boxcars, single file. The other way is there's not a lot of cytoplasm, so you might put it into the small round blue cell tumor differential, where
So
you'd...
then you're going like lung, Merkel, like neuroendocrine
Exactly.
tumors.
So, among the metastatic things, neuroblastoma is one that can look like this, lymphomas, small cell endocrine, and then small cell lung being the key one. And so TTF1, which is a thyroid marker, but also pretty reliably marks small cell lung, is one that we use, and this was positive because this was small cell lung carcinoma. You want to pass or play?
I'll play, yeah.
You'll play. Okay.
So yeah, we have a dermal-based, dermal-based lesion. We're obviously talking about metastasis, multifocal. Kind of like they're punched out in some areas. So you wonder about, could it be breast, could it be a thyroid, some kind of adenocarcinoma.
Yeah, it certainly looks glandular, right? Glandular and kind of high columnar, right? Maybe a little more stretchy than breast usually is.
Yeah, some areas maybe vascular.
And you get a hint of dirty necrosis in the center. And then this one proved to be colon. Again, but key would be met, and then if you've identified it as an adenocarcinoma of unknown origin, any keratin stains that might be helpful in terms of suggesting origin?
Yeah, if I have an unknown adeno, I have to do 720, and we expect 7 negative, 20 positive on that. You can do CDX2 if you really want to chase it.
So CDX2 is one of the things that's more specific for gut. 7 and 20 are kind of broad, looking at adenocarcinomas of the primary. Remember, 7 is a lower number than 20, so it's lighter, so it floats up. So things above the diaphragm tend to be 7 positive, and then 20 was heavier, it sank, so things below the diaphragm tend to be 20 positive. When you get to the very terminal gut, rectal carcinomas often switch, and they're 7 positive, 20 negative. So, at the very, very tail end of the gut, you have a switch. Okay, so this was atypical mole that was removed. So atypical mole rule out melanoma. That was the history.
Right, so looking at it, I mean, it looks pretty benign, with some maturation.
Yeah, and they're kind of tight perivascular arrays, so patchy, perivascular, interstitial, melanocytic goes with what kind of a melanocytic?
Patchy, intervascular.
So patchy perivascular and then interstitial pattern.
Like congenital pattern?
Yeah, like a congenital pattern nevus, and those are often a little large and irregular, so that kind of makes sense that they would have biopsied that to rule out melanoma.
Oh, yeah.
What they didn't anticipate was everything that sat below it.
Right. So, I mean, you see a lot of atypia. It looks like it's in the lymphatic spaces, so like maybe an inflammatory grafts.
Exactly. And this was actually inflammatory transitional carcinoma. The nevus was from a thigh, but inflammatory breast would look very similar. So where's the inflammation for inflammatory breast?
There isn't really any.
Yeah, in the name, right? It's named because it looks like erysipelas clinically, not because it's inflammatory histologically. So what you see is just adenocarcinoma lodged pretty much exclusively in lymphatics, together with an erysipelas-like presentation, most common with breast, but you can see it with other cancers as well. Especially transitional carcinoma is one of the more common ones to do it. Okay. Ying, you're up.
In the first impression, there is a diffused canal cell infiltrating interstitial. So, in the first impression, I'm wondering if it's a metastatic carcinoma from renal.
So, very good. That's exactly what it is. Well done. Someone pass Ying the easy button.
It's right in front of her.
That was easy.
Okay, very good. So you have tubules composed of clear cells, highly vascular. Renal carcinoma tends to be very bloody, glycogenated, clear. There are some markers. CD10 is pretty reliable. RCC, there's an ever-expanding list of more specific markers for renal. CD10 is sometimes still used as a starting place because it's very sensitive, although not quite as specific.
Looks like trying to see if this was mucosal.
Probably skin rather than mucosa.
So the dermal deposit here looks almost glandular, and columnar, some cuboidal,
Yeah.
large. Kind of puts you in the adenocarcinoma type.
Looks sort of like this decapitation secretion. I'd say there's not necessarily much crowding or disorder. of the cells. Your stroma has a lot of erythrocytes and hemosiderin in it,
Like endometriosis.
like endometriosis, which is an important simulant of metastatic adenocarcinoma. And one of the hints is the stroma. Stroma filled with erythrocytes and hemosiderin. I think you guys saw a decidualized endometriosis as well.
Yeah. So you've commented before that you think that on the test they would always have to give you like more of the bloody, like not decidualized, like actively.
Well, I mean, theoretically anything could be given.
Yeah.
You know, that is one part I don't have my hands in.
That's why we don't.
An ordinary is, I think, hard enough.
Yeah.
The fellows need to know all presentations, including decidualized, and it's certainly important to have at least familiarity with. So, okay, umbilical papule.
Oh, the omphalomesentaric polyp.
Omphalomesentaric duct polyp. Very good. So, you know, very benign looking gut epithelium with lots of goblet cells. Looks almost like a hyperplastic polyp if you were in gut, is omphalomesentaric duct polyp. Very good. You deserve the easy button as well.
Is that found in just like congenital in kids, or?
Yeah, it's usually young kids, you know, which helps. So it's not an age where you would expect to have metastatic disease. You would not expect a Sister Mary Joseph nodule in a child.
We got a diffuse, it's like atypical infiltrate. Let's see, it's not glandular or
Highly atypical,
typical.
not particularly screaming, glandular.
Still some cytoplasm.
And when you look at the cytoplasm, see how that's all one cytoplasmic unit and yet there are multiple atypical nuclei in it?
Yes.
So it's like a big syncytial giant cell.
So thyroid, syncytial.
So syncytial, one of the path guys. Yeah, choreo. Carcinoma. Remember syncytial trophoblasts?
Yes.
So choreo differentiation, when you see a usually pretty ugly anaplastic tumor and it has syncytial giant cells, that's one of the hints to look for carcinoma. Paige, we have 2 available heads if you want to. Only if you want to. Yeah. If you're, if we just tilt them a little bit, you can usually get everyone comfortably in there.
We can be very comfortable.
You are also, if you are happy on monitor, you can remain happily on monitor.
Right there.
Yeah, it is a little on the cozy side there. Thank you.
Right, so we have a punch here, and it looks like there's a very sparse dermal infiltrate. And then I'm seeing something that looks pretty different, at the very, very edge. Looks kind of solid. I see one cell that looks kind of like it has a cleared out nucleus.
which is the sort of thing you can see in melanocytic, you can see it in thyroid,
Yeah,
but you can see it in
that's-
other things as well.
Kind of thinking papillary thyroid based on that, but there's not a whole lot for me to go off of.
Yeah. It does look like a big mass maybe sitting by itself in the lymphatic, so possibility of inflammatory carcinoma. Pattern you don't usually see with thyroid inflammatory carcinoma. This one turned out to be breast, but I
Okay.
agree with you, that nucleus, sort of orphan Annie looks a little thyroidish.
Right, so I've got kind of this dense pink stromal thing in the dermis with these glandular-like structures. The nuclei look pretty dark and crowded, so I'm thinking probably some sort of adenocarcinoma.
So, we're certainly in that chapter, and it's glandular, and they do look. They definitely
the
look a
glands
little.
are not themselves crowded, though.
Yeah, I mean they stain a little dark. I have to say that, but they're not so crowded. They're not jumbled. I don't see any Roman arches or anything of that sort. Well, although maybe now that I said that, maybe it's trying right there. Just a little papillary, and this is a teenage male with enlarging breast, and
So this is some ectopic breast tissue.
was read just as benign gynecomastia. So, Nicole, you want to teach us about gynecomastia versus breast cancer?
So the fact is that you don't have any crowded glands themselves. They're not so haphazardly arranged. They're nicely spaced. And if you actually look, while these do stain dark, you have to take into account that, different labs stain things differently. But if you look at the number of layers in the glands, you only have, up to 2 layers and then a myoepithelial layer. They don't particularly look pleomorphic or angulated. They also don't look really monotonous like you would expect in DCIS. And you don't have the hyperplasia. And then that dense stromal reaction is also really good for gynecomastia. It's a little bit denser, but I kind of allude this to, fibrocystic changes that you would see in a female breast. And then you need the history, that it's a guy, and it's usually puberty, that type of age.
So Rachel, you pointed out beautifully the glands themselves were not particularly crowded, were spaced, and by background, I am a derm path. I am not going to sign out gynecomastia on my own. I think that would be foolish, out of the zone where I should be practicing. Let's see. Try to hit some of the high points here.
Looks like clear cell change. Looks like renal cell.
So it looks like renal. So that's that's one that is fairly recognizable, and you really should be able to recognize and then get confirmatory tests. So the elongated clear tubules, the chicken wire blood vessels, and then by confirmation CD10, RCC, a whole host of possible markers that you could use. Let's see what else we need to hit here.
we've got some dermal deposition of some blue cells. A fairly good amount of cytoplasm in there. Bigger nuclei. Kind of nested appearance.
Yeah, and honestly, I mean, I would have looked at this, and my first thought would have been there's no epidermal connection. Well, there actually maybe is focally. So either primary squamous cell carcinoma or epidermotropic metastasis of squamous cell carcinoma would probably have been top on my list. This one actually is a carcinoid, and the carcinoids can be very pink and can mimic squame. Staining and of course history would be helpful.
So certainly a dermal deposit of it appears to be almost nested atypical cells, and there may be forming little lumen.
Yep. So some areas suggestive of a duct or adenodifferentiation.
Probably some sort of adenocarcinoma.
Yeah, not a very nice one. And this particular one was a cutaneous met from ovarian. And they, of course, run a real spectrum of appearance.
That looks like endometriosis.
Looks like endometriosis. You have a columnar epithelium, you have a fibromyxoid stroma with lots of red cell extravasation, lots of hemosiderosis. This is another endometriosis just to reinforce the epithelial layer is columnar, fibromyxoid stroma, lots of erythrocytes. When it decidualizes, this little columnar layer stays but becomes kind of squashed, and the stromal cells become large epithelioid cells in decidualized endometriosis. Okay, that's one more here.
There's something, yeah, there's an infiltrate in the dermis of some kind of sheets of cells. Really displaying the collagen fibers. So I'd definitely have to do some stains.
Yep, agree. In some areas, it looks suspicious for adenocarcinoma with some lumen formation. Look in here. You can be fooled sometimes with squamous carcinomas as well. This one proved to be metastatic breast. Okay, I think we've hit the high points of those. We're going to try to hit a different topic here because it isn't covered. It's kind of a hodgepodge that isn't covered well in the other chapters, and that's the exogenous agents and drug, which is another thing important to be familiar with. So we're going to... Okay.
It's like a suture or a splinter.
Yeah, so the question is that more suture or more splinter? So is it braided going in multiple directions, or is it... Yeah, which is more splintery. So, and when you see a splinter, the first thing you look for is look for chromoorganisms, because it's very common. The ones that get biopsied are often the ones that have a little focus of chromomycosis forming. So Very good.
So it looks like you have some exogenous pigment or a tattoo.
Yeah, it looks tattoo looks kind of bluish, and then you have lots of granuloma. So tattoo reaction. There's pseudoepitheliomatous hyperplasia, PEH with pus. You probably want to stain it for atypical mycobacteria. Get an auramine rhodamine because tattoo pigments are aqueous and often will grow atypical mycobacteria, and there have been outbreaks where you have 1,000 people in a city with mycobacterial granulomas because of one bottle of tattoo ink. But many of them are allergic as well. Blues, but especially reds, are famous for that.
Again, lots of pigment.
Lots of pigment down into muscle, right? Which
So more like a graphite or traumatic tattoo.
yeah, exactly. More like a graphite or traumatic tattoo. So it's the sort of thing you could see with a gun blast. In this case, it was a vicious attack with a number 2 pencil, which can also give you a graphite tattoo.
And we have a blister, looks like one subepidermal.
Subepidermal blister, heavily sun-damaged skin, and then in the epidermis you have this kind of funny structure. Sort of down the middle of the epidermis. Something different altogether. So, anyone thought? Like a caterpillar body. Well done. And caterpillar body goes with?
Porphyria, I keep thinking about that.
Well done. Pass that easy button.
She's been hit it for you. Oh my goodness.
You can do it for me.
Yep.
That was easy.
Very good.
Over there.
And then if you had pseudoporphyria, what kind of drugs, because this is drug and deposition, what kind of things give you pseudoporphyria? So NSAIDs, with the most common one being naproxen. By far, that's like 1,000 to 1. There are other drugs that can do it, but almost all of them are naproxen. So.
Maybe some death in the epidermis.
So, individual cell necrosis, satellite necrosis, some lymphs. Is there a lymphocyte at every site of necrosis, or is there death out of proportion to lymphs?
I'd say probably death out of proportion.
And tell me about the stratum corneum. What's the time course of this onset?
Pretty acute or subacute.
So pretty acute. I don't even see any compact red corneum really at all. It's basket weave. It's a pretty tight basket weave, like you might get on the dorsum of a hand or foot. So put that together, and what are you thinking? So lots of dead reds, acute corneum. GVH absolutely can do it, but tends to be a little more subacute. You usually have a few more lymphs, exaggeration at the acrosyringium, and some background epithelial disorder.
It's like EM.
Like erythema multiforme or toxic epidermal necrolysis. Very good. So, where do you think you are on the body?
I think the main change was lying on epidermis, and I can see some hypergranulary, and then there are some large cells, and in the dermis there is some lymphocytes pervascular.
And we're probably, with the thick corneum, we're probably on an acral site, so a finger or a toe. This makes it a little more difficult. That's just pagetoid dyskeratosis, which means nothing. You have some papillary dermal edema, pallor, and every lymphocyte around the vessel sits on a little background of white. So there's a little bit of edema around those vessels. So the lymphocytes are very discrete, sitting on a little bit of white. So anyone, acral skin, papillary dermal edema, perniosis, and so you would want to screen for what in the patient? Lupus erythematosus, because third to a half of pernio cases are presentation of systemic lupus. Unfortunately, the term lupus pernio has nothing to do with that. That's cutaneous sarcoid of the nose that mimics perniosis clinically.
So pretty superficial infiltrate. Looks mostly lymphocytic.
Okay. And what pattern do you have in here?
It's a spongiotic.
But what pattern do you have over here? More vacuolar interface. So it can't decide whether it wants to be spongiotic or interface. When you see that weird mix, what kind of things do you think of?
Drug.
Drug would
Viral.
be right at the top, viral and syphilis. Well done. You get the easy button for that. So when you see odd mixes of spongiotic and interface, think of drug, viral, syphilis. And this really could be any of the three. This is someone with liver functions going through the roof, facial edema, peripheral eosinophilia.
Dress.
So DRESS, correct. So if DRESS is caused by an anticonvulsant, you tend to have that triad, facial edema, eosinophilia, liver function elevation. What if it's caused by allopurinol? What's different?
Liver involvement.
Yeah, so so less prominent liver and more prominent kidney. And what if it's minocycline? Myalgia and lung. So it looks like influenza. And what if it's dapsone? No eosinophilia. So with dapsone, it's DRESS instead of DRESS, right? The E is missing. So no reliable eosinophilia with dapsone. Important because the often fatal, and you want to you don't want to miss the diagnosis just because it's an incomplete triad. Okay, so here I'm going to walk you through this. There are lots of granuloma, lots of inflammatory, and then lots of these vacuoles, right? So your question is, what's in the vacuole? Could this be a lipogranuloma? What got injected? And in this case, it was hydraulic fluid injection.
Oh my god.
I don't think that one's fair. We're going to skip that.
Looks like quite a bit of spongiosis and papillary dermal edema with some extravasated reds.
So there are some extravasated reds. There definitely is some sponge. Is it more, is it exclusively sponge? Is there
There's a
interface?
little interface there too.
And dead reds, right, which go with interface, not with spongiotic. So you got a mix of patterns. Should that make you think of anything?
Drug, viral, and syphilis.
Drug, viral, and syphilis. And tell me about the time course.
Pretty acute.
Pretty acute. Dead reds, so, you'd think of syphilis, I suppose could be that acute, but, patients tend to be a little more subacute when they present with secondary syphilis. Viral, again, usually a little more subacute. Very acute corneum like that leads you maybe towards drug, and with lots of dead reds, you might think of something like fixed drug or EM. And so for fixed drug, you'd look for deep pigment, papillodermal fibrosis, EOs, polys, some kind of polymorphous infiltrate. This one, they called EM. To me, it looks maybe a little fixed druggy. I'd have to know the history. Let's see. Presumably we have tissue here somewhere. There we go. That is one faded bit of tissue, so I'm going to walk you. Let's see if we can do this one at all. That's really bad. We're acral. We're subacute. You can see that zone of red. There's an interface dermatitis that's vacuolar, and there is some epithelial disorder that's squeezing a lot from this particular slide. But this was a toxic erythema of chemo, an acral erythema. It's been described as looking like grade 1/2 GVH.
Piece of tissue, possibly some exogenous material.
Yeah, kind of granular.
Deposited here.
So tell me about the inflammatory reaction to it.
It's not that brisk or robust.
Yeah, or not present
Not
at all. So a big hunk of granular foreign substance that's not inciting any inflammatory reaction whatsoever.
Catalog.
Yeah, that's exactly what it is. It's Kenalog. So, it's actively suppressing the inflammatory reaction, and that's what Kenalog looks like. You've seen it before in keloids and things of that sort. That's a nevus, right? But then on the background, see all those little, all that stippling?
Oh, yeah. Is it pigment?
It is pigment, but it's not melanin.
Looks too dark to be melanin.
Exactly, too dark, so it could be tattoo.
Traumatic.
One of the other things we're going to do is we're going to flip down the condenser, and you can see it's not diffractive at all. A lot of exogenous pigments are diffractive. This one is not at all, and patient was, I'm making up a history, but this patient was addicted to Goldschlager. And so that's chrysiasis. So chrysiasis, you become a very gray human being, like with Argyria, but Argyria is brightly diffractive and tends to be in the lamina propria of sweat glands, whereas chrysiasis is all through the dermis and doesn't diffract at all. So that absence of diffraction is actually one of the diagnostic criteria for chrysiasis. Let's see if there's enough tissue here to look at.
I think I saw it. It's just
Somewhere here there was tissue. Okay. There we go, look at that! Okay, so another pathetically faded piece of tissue, but you can see pigment, right?
yeah, there's some sort of brown pigment in there.
And now let's try This one, let's see if we can get that. Might have to go lower power to see it. Okay. Can you make out how that is brightly diffractive, how it becomes bright little spots there?
Yeah.
So it's sort of the opposite of what chrysiasis would do. And that's something that hemosiderin can do. When I would look at this, probably the first thing I'd think of would be minocycline pigment, but this was actually imipramine pigment, which is another one of the brightly diffractive pigments. Let's see.
Is it still me or
I got it.
okay.
That, up to you.
There's maybe scar and I'm not sure.
Sort of amorphous pink stuff.
Yeah.
Yeah, that is distinctly fissured and cracked. So amorphous pink stuff, fissured and cracked, sitting in the dermis,
Amyloid.
associated with red cell extravasation. So amyloid would be absolutely your thought. This was a patient with Waldenstroms and deposition, but amyloid thioflavin T would be a great stain. Crystal violet is is very sensitive for epidermally derived amyloid, but immunoglobulin derived amyloid does better with thioflavin T or Congo red.
How does colloid milium look different than that?
Colloid milium stains a little. It picks up amyloid stains, but weakly, and then on H&E, colloid milium, much more fissured. Background of solar elastosis, and you can see transition between the elastotic fibers and the colloid milium. That's the best way to do it. Let's see what else we have here. Oh, that's horrible. That slide. Some of these are blistered. Let's see if this one is good. Okay, where on the body do you think you are?
So he's got a pretty thickened stratum corneum, so I would say barely acral skin.
Probably acral skin.
There seems to be some splitting there, but that could be artifact.
Okay, I agree. That's probably artifact.
And the
Is your basal layer intact?
yeah, it's intact. I mean, maybe a couple of the sites, but they're hard to see.
So basal layer is usually columnar.
Yeah.
Are these columnar or just squamous cells?
No, they just look like squamous cells.
So your basal layer is totally gone. You have a few vacuoles with lymphs, but they're few in number. And when you look at your epithelium, cells stay round pretty much towards the top. They don't flatten out normally. So you've got you're on acral skin, you've got a little bit of interface dermatitis, you've got a little abnormal maturation, not much inflammation, and it's someone with very sore, red to violaceous hands, undergoing chemo. Patient over at Hollings.
Like drug?
Yeah, and that would be typical for toxic erythema of chemo. So toxic erythema of chemo, also called acral erythema of chemo, because it tends to be hands and feet, looks sort of like grade 1/2 GVHD. So you have often loss of the basal layer, but it's pauci inflammatory. And so that disconnect of pretty dramatic loss of the basal layer with very little inflammation is kind of typical for the toxic erythema of chemo. Okay, we've got just a little bit of time. You want to grab some potpourri, or do we have some other? Let's see what else we have here that would be good. We have others in there that were good. Okay. Here's one that we did not cover earlier. So,
Well, certainly some glandular spaces. It's not markedly atypical off the bat, but certainly could be something metastatic. Appears to be a myoepithelial layer, but I'd want to know location.
so if you want to confirm presence or absence of myoepithelial, any stain you might do.
You can get calcitonin,
You-
P63.
Yeah, P63, calcitonin, any of those. It's multi-layers thick, not particularly columnar, which is a little bit worrisome.
We're in the eyelid.
That would be, a very good thought for an endocrine mucin producing.
Not so many hairs, though. Oh, there's one.
We're not lid. There is some.
Thyroid, maybe.
Yeah, exactly. There's
Colloid.
some red material suggestive of colloid, and this was papillary thyroid. The nuclei, I don't see lots of orphan anti-type nuclei or nuclear pseudo-inclusions, which are usually hints that you look for in papillary thyroid. They're not real prominent in this case. But that was the history. Let's see what else we have. Okay, this is something different we haven't looked at before.
That is a very blue chondroity stroma.
That is a very steel, gray, blue, sulfated mucin chondroity stroma.
Primary things, those are definitely atypical cells. So
Atypical cells and
those
kind of
look
vacuolated.
a little phycoliferous.
They do look a little phycoliferous
So
with
like
the
a chordoma?
vacuolization. Like a chordoma. And if they're atypical, it's likely a true chordoma. Paracordomas fall into the myoepithelioma group, everything from pleomorphic adenoma to mixed tumor to malignant myoepitheliomas in skin. True chordomas are axial, commonly presacral, metastasized. This poor guy looked like the Michelin tire man with about 40 pounds of metastatic chordoma in his skin. Okay, let's see. Okay. Something common but important to recognize. Let's find a really good site for it. So, you've got altered papillary dermis here. And let's try to find a good area on which to focus. Here we go. Well, we
I'll
can.
give you two. The other one might be better.
Okay, the other one might be better to get in focus. Let's see. Yeah. There we go. Irregular, kind of basophilic chunks, granules within histiocytes, and some necrotic collagen. Put those together, and it looks like cautery change. So that's the change you see in a biopsy site. Tattoo either from Moncell's solution, which would be darker, and the collagen in particular would look brown and necrotic, or in this case, aluminum chloride. So those tattoos are important to identify mainly because sometimes the scar is not very obvious. So they say they're doing a re-excision, and you don't see an obvious scar. Well, that's something you have to alert the clinician to. But if you see the aluminum chloride tattoo, you know it really was the biopsy site. So it can be helpful that way. Let's see what else we got here.
It's very blue.
Very blue, lots of solar elastosis, and I'm actually not seeing enough pigment to make that one fair. Let's try this one. See if that's a little better.
There's some pigment there.
Yeah, there's definitely more pigment in here, and although some of this looks like formalin pigment that's deposited on the outside of the slide as a distractor. So let's skip that one. There we go. There you can see an exogenous pigment, right? And so things that, first off, you want history, right? Minocycline pigment tends to dual stain with iron and melanin stains, which can be helpful. You look for presence or absence of diffraction. This one has no diffraction whatsoever, which is one of the hints that it's chrysiasis. Again, so gold deposition. And with that, I think we're going to stop. That was kind of a hodgepodgey chapter. For the rest of the year, it actually becomes pretty fun because we do all potpourri from now till the end of the year. So we aim for pretty high volume potpourri.
So much fun.